Good morning, everybody. It's nice to see everyone again. So as Bridget said, I'm Terry Mata. If you've never met me or seen me, you've probably heard about me behind the scenes, answering MDS questions and that kind of thing. As Bridget said, I will be going over the changes in the RAI Manual item sets with you this morning. Next slide, please. These next few slides actually provide you with the acronyms that are going to be used during this presentation. And if you look in your packets, number 3 is a acronym list, just in case you want to follow along and you're not familiar with some of these acronyms. So if you could advance through the acronym slides, please, to slide 5. So these are the objectives of the session today. After participating in this session, you should be able to identify the relationship between the Impact Act of 2014 and data collected for the SNF QRP. You should be able to list at least 3 RAI manual changes, name 3 reasons the item sets changes were made, and list at least 1 new, 1 revised, and 1 removed MDS item. Next slide. First, we're going to have just a very brief discussion of the Impact Act of 2014. Next slide. The Impact Act was a bipartisan bill passed on September 18th of 2014 and was signed into law on October 6th of 2014. The Impact Act requires that patient-resident assessment data be standardized across post-acute care settings, and the idea here is that once data is standardized, that it would enable quality of care, improved outcomes, provide data element uniformity, and the ability to compare data across post-acute care settings. We're also looking at improving person-centered, goals-driven discharge planning and allowing for electronic exchangeability of data, as well as to coordinate care across the settings. Next slide. You may have seen this graphic before or one similar, which really is a visual of data element alignment across the post-acute care patient-resident assessment instruments with the goal of uniformity between them. So that little diamond in the middle, although this graphic doesn't really show the alignment that we have achieved over these past several years, which is nearly 100% between the MDS and the LTAC care dataset in IRFPI, it does provide the idea of what the goal is, which is uniformity. So here are the goals and guiding principles of achieving standardized data. Some of the goals are to foster seamless care transitions with data and information that can follow the patient or resident, to assess quality across settings and evaluate longitudinal outcomes for patients and residents across care settings, as well as to improve outcomes and efficiency and reduce provider burden. Some guiding principles are that the data should be reusable, informative, and meaningful to providers. It should increase the reliability and validity as well as facilitate care coordination. So in terms of interoperability, having standardized data, again, across using the same language makes it easier to communicate across the settings so that you're all using the same language and saying the same things. So, for example, one setting isn't saying pressure ulcers and another saying bed sores and another saying decubitus ulcers, that we're all using the same language. So the relationship between the Impact Act data collected for SNF QRP is that there are reporting requirements in the Act which established the SNF QRP in fiscal year 2016, that SNF PPS rule. Per that statute, SNFs that don't submit the required quality measure data may receive a 2 percentage point reduction to the annual payment update, or APU, for that particular payment year. For more information regarding the SNF QRP, you can always visit the SNF QRP website, for which the URL has been provided on this slide, and we'll also have Robin actually show how to navigate that system. So why were there changes made to the MDS and RAI Manual for 2019? Well, some were due to the Impact Act, which required the standardization of some data elements. Others were to align items across that support cross-setting quality measures, such as the pressure ulcer injury measure, medication reconciliation, and the function measures. Some items, as we'll see, were removed from some of the item sets, and some item sets are totally gone. There were also some changes that were made due to quality measure changes, and of course, some of the changes were also driven by the patient-driven payment model. Okay, so now we'll move on to discuss the revisions to the RAI Manual and the item sets. This is a list of changes to the RAI Manual by chapter and section, and we're mostly going to discuss the changes that are not otherwise discussed elsewhere in the training. So tomorrow I'll be going over A, I, J, and O changes. Anywhere that information is kind of cross-referenced in chapters like Chapter 2, I'll briefly go over it today, but tomorrow in that presentation I'll go a little bit more in depth. Section GG, I won't talk about those changes because you're going to get an entire presentation on Section GG. So I'm going to start with some of the high-level changes that have occurred in the manual and the item sets, and then talk a little bit more in depth about some of the changes. These global changes are changes that have occurred throughout the manual. So acronyms have been spelled out the first time that they are used, with the acronym parenthetically following. The URLs throughout the manual have been updated. Typographical and grammatical errors have been fixed where we found them. And where page numbers have been used as a reference before, what will be used going forward are references to sections and/or chapters. As you can imagine, keeping up with page numbers when things change is very difficult. So they've started to go a little bit up one level. CMS has also standardized the Quality Improvement Evaluation System assessment submission and processing system to Keys ASAP, which is a lot easier to say. Pressure ulcer has been revised to pressure ulcer injury where appropriate, and the coding scenario at the end of Section M was updated to include coding for discharge assessment versus the PPS, and the phrase mental retardation in federal regulation was removed when referring to intellectual disability. So there's been guidance added throughout the manual in relation to two new item sets that have been added, one which is associated with the new patient-driven payment model, or PDPM, and the other having to do with state reporting requirements for payment. Because the term Medicare refers to parts of Medicare beyond Part A, so we have Part C, Part D, Part B, the term Medicare has been replaced with Prospective Payment System, or PPS, because that's really what we're talking about in SNF. We're talking about Medicare Part A. So for example, where the terms Medicare assessments, Medicare requirements, Medicare schedule were used, the references are now PPS assessments, PPS requirements, and PPS schedule. And finally, throughout the manual, all references to the 14, 30, 60, and 90-day PPS assessments, OMRAs, and the swing bed clinical change assessment have all been removed due to the PDPM, under which these assessments, as you know, are no longer necessary. There are two new assessment types, as I've mentioned. They're both optional assessments. The first is the interim payment assessment, or the IPA, which is signified by coding A0310B equals 08. And the second is the optional state assessment, or OSA, which is signified by coding A0300 equals 1, yes. For the IPA, the assessment reference date, or ARD, can be set for any time after the ARD of the 5-day. If providers opt to use this assessment, remember it's totally optional, it must be completed at Z0500B within 14 days after the ARD, and it needs to be submitted within 14 days of completion. You do need to be aware that if you complete the IPA, you are going to change payment for the rest of the SNF PPS stay for that resident. And regarding the OSA, again, this is another optional assessment. It is not federally required. So this is a state assessment for payment purposes. The set of items include the items that are required to calculate the resource utilization group, or RUG 3 and 4 scores. And I'll talk a little bit more about this tomorrow, but on the OSA only, you're going to notice that there's an item at it's A0300B, that you won't see on any other item set, and that's really to show the state what type of assessment you're going to be completing. I'm a little bit ahead here. Can you please go back to slide 17? Thank you. So now we're going to look at some of the changes in Chapter 2. As you can imagine, with the removal of several assessments, the addition of two new ones, this chapter has changed quite a bit. There are, however, a couple of overall changes in Chapter 2 that have occurred that revolve around a new policy called the interrupted stay, as well as implications of that new of the new item sets on policy. So I'm going to ask you to review Chapter 2 very, very, very closely because there have been a lot of changes there. So under the change in ownership section in Chapter 2, and due to the addition of the IPA, the change in ownership information under the common situation where an owner assumes the assets and liabilities of the prior owner was revised. If the resident is in a Part A stay, an IPA could be the next PPS submitted under the existing provider number if the 5-day had been combined with the OBRA admission. So just remember, again, that if you do complete an IPA in this situation, you are going to change that payment for the rest of the stay unless another IPA is completed. So before we talk a little more in depth about the changes in the 5-day assessment window, I just wanted to reflect on the fact that we now only have three PPS assessments. And I'm assuming that most people are very happy about that. It's pretty exciting news, less burden on providers, we hope, and more accurate payment. But we do still have the 5-day, which is indicated, as, again, as I said, by A0310B equals 01. And this is now the only scheduled PPS assessment. Then there's the IPA. That is the only unscheduled PPS assessment, which is optional. And then we also have the NPE, our party discharge assessment. So no more OMRs for Medicare, no more of those other interim assessments. So let's take a look now at the changes that have been made to the 5-day assessment window. The 5-day has defined days within which the ARD at item A2300 must be set. The prescribed window for the ARD for the 5-day includes days 1 through 8. So before, where you had grace days that you could extend out to 8, CMS just said, let's just make that window days 1 through 8. So the first day of the Medicare coverage for the current day is considered day 1 for PPS scheduling purposes and for purposes of the variable per diem adjustment. Some of the phrases that I'll be saying as I go through Chapter 2 will be discussed in other presentations, so you'll learn more about the VPD from John tomorrow. In most cases, the first day of the Medicare Part A is usually the day of admission. However, we all know that there are some situations where the beneficiary may qualify for Part A at a later date. Here's a little bit more information about the 5-day assessment that was added to the scheduled and unscheduled assessments section in Chapter 2. As you can see here, this addition refers to the setting of the ARD that I just spoke about on days 1 through 8. Also, in this same section, information about the IPA has been added to show that the IPA may be completed after a 5-day when deemed appropriate by the provider. The IPA will capture changes in the resident's status or condition, and remember, again, that it will change payment when you complete it. And here's more detail about the 5-day assessment. Again, the ARD must be set for days 1 through 8, and it must be completed as indicated by the date in item Z0500B within 14 days of the ARD. So the ARD plus 14 days. The 5-day authorizes payment for the entire PPS stay until an IPA is completed, and the 5-day is still the first PPS required assessment to be completed when the resident is first admitted for a SNF stay. The 5-day will also be the first assessment to be completed if the resident is readmitted to the facility for a Part A following a discharge assessment return not anticipated, or if a resident returns more than 30 days after a discharge return anticipated. The 5-day, however, is not required if a resident returns to a Part A covered stay following an interrupted stay. And I'll talk more about that interrupted stay policy in a minute, but the 5-day is not required in the situation of an interrupted stay because an interrupted stay does not end the Part A PPS stay. If a resident changes payers from Medicare Advantage to Medicare Part A, the SNF must complete a 5-day assessment with the ARD set for one of the days 1 through 8 of the Part A stay, with the resident's first day covered by Medicare Part A serving as day 1, unless it's an interrupted stay. So let's look at the IPA. There are situations where a provider may want to complete an IPA to capture changes in the resident's status and condition. The IPA is solely under the discretion of the provider to complete, as it is an optional assessment. CMS is not forcing you to complete one. I know that some facilities or corporate offices have suggested times where you may want to complete one, but remember, CMS is not telling you have to complete one. It's totally optional. And again, the ARD can be set for any day of the SNF PPS as long as it's after the ARD of the 5-day. If the provider chooses to complete an IPA, it must be completed within 14 days after the ARD. And again, the IPA authorizes payment for the remainder of the Part A PPS day beginning on the ARD. It has to be submitted electronically, as you do with your other assessments, into the KEYS ASAP system within 14 days of completion, and this assessment can't be combined with any other assessment. So this is a standalone assessment. When you complete an IPA, you can't combine it with anything else. Okay? So information was added to the Part A PPS discharge section to accommodate this interrupted stay policy. Under our current requirements, the NPE is completed when the resident's Part A PPS stay ends and he or she remains in the facility. A0310H identifies whether the discharge is a Part A PPS discharge assessment for the purposes of the SNF QRP, and this requirement remains the same except in cases where there is an instance of an interrupted stay. So how does the interrupted stay policy affect the completion of the Part A PPS discharge assessment? So what I'll do is I'll quickly describe and define what the policy is so that there's some context here with the changes in Chapter 2. An interrupted stay occurs when a resident in a SNF stay is discharged from SNF care, that is, they're discharged from Part A, either physically or discharged, or the resident remains in the facility, and then subsequently resumes SNF care in the same SNF for a Medicare Part A covered stay within a 3-day interruption window. And again, tomorrow I'll go over it more in depth, what all of that means, including the interruption window. So the entry, OBRA, discharge, and reentry algorithm has been updated to remove A0310C and A0310D in the footnote below the diagram, which you see that little box in yellow, since these items are no longer collected on the item set. There were some changes made in Section 2.10, and these are mostly related to the IPA. As you know, when the OBRA and PPS timeframes coincide, one assessment can be used to satisfy both requirements. And this still holds true. The PPS and OBRA assessments can be combined when the windows overlap for a common ARD, and when you do combine those assessments, the most stringent rules for the ARD, item set, and COG completion still apply. As is currently the case when combining a 5-day with an OBRA admission, use of the latter end of the OBRA admission would cause the 5-day to be late. So when you're setting the ARD for a combined OBRA admission and 5-day, the window within which to set the ARD in order to meet the requirements to avoid a late 5-day would be, of course, days 1 through 8. So additional updates to the tables that denote the item sets by assessment type for SNF and for swing beds were updated to include the revisions to the 5-day, add the IPA and swing bed discharge, as well as the types of combination assessments. There was also a statement in this section that read that tracking records cannot be combined with other assessments. The IPA was added to this statement because the IPA, again, is a standalone and cannot be combined with any other assessment or tracking record. Section 2.11 details the assessment combinations. Each of the assessments listed here had the combination language modified based on the new assessment window and elimination of the gray stays in the 5-day. And the various PPS item sets have been eliminated, so all of that language has also been removed from this section. So this section is quite a bit pared down from what it used to be. There have been quite a few changes under Section 2.12, which is the section that talks about factors impacting SNF PPS assessment scheduling. Information was added to this section to accommodate the new interrupted stay policy. So I'm not going to spend a lot of time going through all of the details on these next few slides, but I'm going to highlight some important information. In this portion of Section 2.12 that you see on the slide, the interrupted stay has been added to when a resident is admitted to acute care facility and returns. If a resident under a Medicare Part A stay is admitted to an acute care facility and returns to resume a SNF Part A stay, we know that a new 5-day is usually required. But we just learned that in an interrupted stay, as long as a resident returns to the same SNF and resumes Part A services within a 3-day interruption window, no 5-day is going to be required on that reentry, only an entry tracking form. Again, a provider could complete an IPA if they so desired. Next is the situation where a resident is sent to an acute care facility, not admitted, and is not in the SNF over midnight. The current policy is that if the resident was in an acute care facility for less than 24 hours, no new 5-day is required. The addition here is that an IPA may be completed if the provider deems it appropriate. The payment implications, again, in this situation remain the same. That is, the day preceding the midnight on which the resident was absent from the nursing home is not a covered Part A day. In addition, that day would also be skipped for the purposes of the PDPM variable per diem adjustment. In the case where a resident takes a leave of absence from a SNF, a phrase was added here that there may be payment complications. And the example given here is unchanged from the current information that's already in this section. If the resident has a leave of absence during part of the assessment observation, the facility may include services provided during that absence when permitted by MDS guidelines. When a resident is discharged from Part A and physically from the facility and returns to resume Part A services, the OBRA and Part A PPS discharge would be required and may be combined. On return to the facility, it is considered a new Part A stay as long as resumption occurs within the 30-day window allowed by Medicare, and a new 5-day and entry tracking record would be completed. If the resident was discharged, return not anticipated, the facility would also have to complete a new OBRA admission. So your OBRA rules still apply, even though here we're really talking about the Part A stay. But just remember, your PPS rules are different from OBRA rules. So when somebody gets discharged, you're still going to have to do an OBRA discharge where it applies, and an OBRA admission when they come back, if it applies. However, in cases of an interrupted stay, that is, if the resident is discharged from Part A, left the facility, and returned to resume Part A within that 3-day interruption window, only the OBRA discharge would be required. And an entry tracking record would be required, but no new 5-day. If the resident was discharged, return anticipated, no OBRA admission would be required, right? That's the current policy. But if the resident was discharged, return not anticipated, the facility would have to complete a new OBRA admission. And the beneficiary, of course, anytime they come back, should also be assessed to determine if there was a significant change of status. In the situation where a resident's Part A stay ends, but the resident remains in the facility in a Medicare and/or Medicaid certified bed with another payer source, the facility must continue with the OBRA schedule from the date of admission, so that's A1900, and that they would need to complete a Part A PPS discharge. If Part A benefits resume again, there's no reason to change the OBRA schedule, right? PPS schedule would start again with the 5-day, unless it's the case of an interrupted stay. The next portion of this section refers to noncompliance with the PPS assessment schedule. According to the Code of Federal Regulations, an assessment that does not have its ARD set within the prescribed ARD window will be paid at the default rate for the number of days that the ARD is out of compliance. Any frequent late assessment scheduling practices or missed assessments may result in additional review. And the default rate in this case would take the place of the otherwise applicable federal rate. The rate is equal to the rate paid for the Health Insurance Prospective Payment System, or HIPS, code that reflects the lowest acuity level for each PDPM component, and would generally be lower than the Medicare rate payable if the SNF had submitted an assessment according to the prescribed assessment schedule. If the SNF fails to set the ARD within the defined ARD window for a 5-day and the resident is still on Part A, the facility must complete a late assessment. The ARD can be no earlier than the day the error was identified. The SNF would bill the default rate for the number of days that the assessment is out of compliance. So that is the number of days between the day following the last day of the available ARD window and the last day of the ARD, including the ARD. The SNF would then bill the HIPS code established by the late assessment for the remainder of the SNF stay unless the SNF chooses to complete an IPA at some point. So for example, a 5-day with an ARD of day 11 is out of compliance for 3 days and therefore would be paid at the default rate for days 1 through 3 of the Part A stay. And the HIPS code from the late 5-day assessment would be used for the remainder of the Part A stay, again, unless you determine that you want to complete an IPA. Section 2.13, the expected order of MDS records, and Section 2.14, nursing home and swing bed item set code reference tables were updated to include the IPA and to remove the retired PPS assessments. There are 2 additional item sets that are not listed in this table, and the first item set is related to inactivation requests, so that XX record. And the second item set is the OSA, which is not federally required, but may be required at the discretion of your state agency for state payment purposes. So let's move on to Section C. So C0100, the updates here are that the PDPM cognitive level uses a speech-language pathology payment component in the PDPM. Only in the case of PPS assessments, the staff may complete the staff assessment for mental status for an interviewable resident when the resident is unexpectedly discharged from a Part A stay prior to the completion of the BIMS. So in this case, the assessor would enter 0, no, in C0100, should brief interview for mental status be conducted, and then they should proceed directly to the staff assessment of mental status. So that's something new. The next update is in Section D, and it's the safety notification associated with the PHQ. So these items are in the PHQ-9 as well as the PHQ-9 OV or observational version. These items have been removed. Although you will no longer see these items on any item set, I think it goes without saying that if staff should still report these kinds of incidents of potential for resident harm to the appropriate practitioner so that appropriate follow-through is had. The next change is in nutritional approaches, and it's under the percent intake by artificial root. These items are K0510, nutritional approaches, and K0710, percent intake by artificial root. There were references removed regarding potential state requirement for completion of items that are no longer collected by CMS. And there was text in Section K and elsewhere in the manual regarding items that are no longer collected by CMS that were also removed. Under nutritional approaches, mechanically altered diet and therapeutic diet are no longer collected by CMS if the resident is not a resident. So that not a resident column. So as you can see in the new snapshot of the item, which is on the bottom right, the checkboxes for K0510C1, mechanically altered diet while not a resident, and K0510D1, therapeutic diet while not a resident, have been removed from the item set. In K0710, the proportion of total calories received through parenteral or tube feeding while not a resident, K0710B1, average fluid intake per day by IV or tube feeding while not a resident, are also both removed. And this is due to the fact that this column is actually not going to be collected by CMS anymore. So in the snapshot in the bottom right, you see there's only 2 columns, column 2 and 3, which are while a resident, and then during the entire 7 days. The next item we'll look at is the respite care item, and this is O0100L. This item has been removed from the item set altogether as it's no longer being collected by CMS. And you'll see in item V0100, items from the most recent prior OBRA or scheduled PPS assessment, that items that were removed in Section A that denote the prior PPS scheduled and unscheduled assessments that have been retired were also removed here in Section V, and the IPA was added. Okay. Due to the addition of the OSA, changes were made in Section X, correction record. The item X0570, optional state assessment, is a new item that was added. And this item tracks back to items A0300A and B on the existing record to be modified and inactivated. So on the modification and activation request for item X0570A, it should match what the current value is on A0300A, which is on the prior erroneous record that's being modified or inactivated. The same goes for X0570B. You're going to fill that box with the assessment type code exactly as submitted for item A0300B, the assessment type on the prior erroneous record to be modified or inactivated. Item X0600, type of assessment and tracking, which is the match to A0310, type of assessment on the existing record to be modified or inactivated. As you can see here, the retired PPS assessment response codes have been removed from X0600B and X0600C and D, and the IPA was added. The corresponding instructions, of course, related to the removal of these items were also removed from the manual. X0900, the reasons for modification, was also updated. And this was updated to remove the retired PPS assessment response code X0900E, the end of therapy resumption EOTR date. The related manual instruction for this item was also removed. And in Z0100 Medicare Part A billing, the term RUG was deleted from Z0100B so that it now just says version code. And the parenthetical statement in Z0100A RUG group, followed by assessment type indicator, was also removed. Z0100C, is this a Medicare short stay assessment, was removed as this policy no longer exists under PDPM, and that language was also removed in the manual. The rationale for Z0100 was updated to include language related to the PDPM case mix version code and the HIPS modifier based on the type of assessment completed. And the definition of the HIPS code was also updated to include information related to the PDPM, so it's been a little bit restructured. Item Z0100A, Medicare Part A HIPS code, is a 5-position billing code with the first 4 positions representing the PDPM clinical case mix, and the 5th is that assessment type indicator. If your software does not calculate this for you, you can use the worksheets in Chapter 6 of the RAI Manual to help you. And in the case study tomorrow, we're going to be doing that. John and Penny John and Jen are going to be walking you through that. So like the RUG code, the HIPS takes into account all MDS items used in PDPM logic. Just as a reminder, for PDPM, it does not include the values in items 00400 therapies. And typically the version code is calculated for this, but if it's not, you're just going to enter that PDPM version code in the spaces provided. Item Z0150, Medicare Part A, non-therapy billing. This item was removed because it is not needed under PDPM. Z0200 and Z0500, state Medicaid billing and alternate state billing. These items have been updated to remove the term RUG, and additionally, Z0200C, is this a short stay assessment, has now been added here for those states that still need it for their RUG score, along with the instructions to complete this item. And in the insurance billing item, Z0300, the term RUG was also removed here from both Z0300A and B. And for Z0500B, signature of RN assessment coordinator verifying the assessment completion, the italicized print on this slide is what was added. Use the actual date that the MDS was completed, reviewed, and assigned as complete by the RN assessment coordinator. This date must be equal to the latest date at Z0400 or later than the dates at Z0400. So what this is saying here basically is that the date here can be on or after the date at Z0400. So now we're on to Chapter 5, Submission and Correction of the MDS Assessments, where there were several changes made. The first update that we're going to look at in Chapter 5 relates to transmitting MDS data. In Section 5.1, there was a statement added to support the OSA submission through Keys ASAP. Providers will be able to submit the OSA to Keys ASAP, just like you already do for your other MDS assessments. And under Section 5.2, timeliness criteria, the submission timeframe for MDS records table has been updated to include the IPA and remove other assessments that have been retired. And in Section 5.3, validation edits, fatal record error information has been updated to reflect the rejected records must be corrected and resubmitted unless the fatal error was due to submission of a duplicate assessment. And that makes sense, right? Because since there's a duplicate assessment, there's already an assessment in Keys ASAP. So you wouldn't be resubmitting an assessment under that situation. Make sense? And the HIPS code information in Section 5.4 was updated to state that the HIPS codes are billing codes used when submitting Medicare Part A SNF claims to the Part A or Part B Medicare Administrative Contractor, or the ABMAC, and that the HIPS code under PDPM consists of 5 positions. So as you can see in this graphic, the first position is the physical therapy, occupational therapy payment group. The second is the speech language pathology payment group. The third position is the nursing payment group. The fourth position is the non-therapy ancillary payment group, and the fifth is your AI code. Group or language was also updated to remove references to RUG 4 and replace them with PDPM, as seen in the italics on this slide. Standard grouper logic and software for PDPM and the AI code are provided by CMS on the MDS 3.0 website. The HIPS codes to be used for Medicare Part A SNF claims are included on the MDS and are the items Z0100A and B, which we've already gone over. So Z0100A is most often used on the claim, and Z0100B is the version code for the PDPM that was used to determine the PDPM payment groups, represented by the HIPS code. Just a note here is that an error in one of these items usually will elicit a non-fatal warning, but the record can still be submitted. In Section 5.7 of this chapter, CMS has decreased the number of years that a correction can be submitted. So it's been decreased now from 3 years to 2. So just be aware of that. And the last chapter we're going to review is Chapter 6. In the change table of Chapter 6, if you've noticed it online, CMS notes that this chapter was extensively revised, obviously due to the changes in the payment system, and that users are highly encouraged to review the chapter in its entirety. So highlights of the changes in this chapter were related to PDPM, and they include the changes to the HIPS code, which we just covered, changes in the classification categories, clinical and functional, based on Section GG, the addition of the PDPM component tables for the first through the fourth characters of the HIPS. The AI code table has been updated to only include the IPA and the 5-day. There is new language added there about the interrupted stay policy, the definition for interrupted stay, and the interruption window. All of that is in this chapter, as well as in Chapter 2. There is also additional language in Chapter 6 about SNF PPS noncompliance related to late and missed assessments. Section 6.3 describes the PDPM. It's important to mention again that the amount of therapy provided doesn't come into play when determining the payment under PDPM. However, PDPM adjusts payment for each major element of the resident SNF's care, especially for PTOT, SLP nursing, and non-therapy ancillaries. Section 6.6 is where the PDPM calculation worksheets can be found. So they are there already if you want to take a look at them and try to work through them yourselves. These were developed to provide clinical staff with a better understanding of how PDPM works, just like your old calculation worksheets. These worksheets translate the standard software code into plain language to assist staff in understanding the logic behind the classification system. When completing the calculation worksheets, first there's a calculation of the resident's cognitive level, and then the worksheets go on to provide users with the steps to identify the primary diagnosis, the clinical category, the function score, case mix groups, and the payment component tables, which you'll use to obtain the payment component for PT, OT, speech, and non-therapy ancillaries. There is a calculation of the variable per diem adjustment, and then a calculation of the total case mix adjusted PDPM per diem rate in that section as well. And finally, just when you thought there couldn't be possibly more changes, there are some in the appendices. In Appendix A, the definitions and acronyms were updated. The definitions were added to interrupted stay, for interruption window, and for the patient-driven payment model. And all of these acronyms that you see on the right side of this table, I did use during this presentation, except for SSN, which is your social security number, and TPN, which is total parenteral nutrition. In Appendix C, pressure ulcers was changed to pressure ulcer/injuries, and the URL to the Alzheimer's Association resource page was updated. And in Appendix G, the URL was updated for the MDS 3.0 Provider Users Guide. So I realize that this was a lot of information to take in. I do encourage you to thoroughly read through Chapter 2 and Chapter 6 because of the massive changes that occurred in those two chapters. But I do hope that you did learn in this lesson the relationship between the Impact Act and the data that's being collected by CMS for the SNF QRP about the RAI Manual item set changes and why they were made. Now, if you look at your handout number 4, that's the document that Bridget talked about, which is the action plan. And I encourage you to use this throughout all of the presentations as you're listening. If you need to record any ideas that you thought of as you heard the presentation in terms of what you might need to do back at your facility as a result of these updates. I'm sure a lot of you are already planning staffing education or sending folks to different education opportunities within your state. Okay, so now we encourage you to submit your questions about this presentation through Slido. Don't forget, as you're looking through Slido, you'll start to see questions come through. If it's a question that you had in your mind, please upvote that question instead of asking the same question. The more you upvote a question that's already in Slido, it'll bump it up to the top, and we'll prioritize it to answer in our Q&A session. So thank you for your time and attention. I'm going to now turn the podium over to Bridget. Thank you again.